Okay, this tutorial is about field testing. The International Headache Classification is a living document. It's constantly being examined in scientific study, and this we call field testing. Here's an example. Nummular headache. Here are the diagnostic criteria. What can you do if you think that this needs to be revised? Well, you just have to gather then a lot of cases of localized cranial pain without regard to the diagnostic criteria of a nummular headache. And then when you have a large material of such patients, you apply the existing diagnostic criteria for nummular pain, and you analyze those people who fulfill the criteria and those people who don't fulfill the criteria. And it's then possible to find out maybe that some patients fall under the diagnostic criteria, but they don't actually have it for some reason. And then you would need to tighten the criteria. And other people who don't get the diagnosis according to these criteria, you have some good arguments that they should be included. And that would mean to open the criteria a little bit in certain aspects. And that's basically, in short, is how we do field testing. Let's take a look at an example. Headache attributed to transient ischemic attack, according to ICSD-3. There's a headache, there's a TIA, and evidence is of causation is both of the following. Headache has developed simultaneously with other symptoms and or clinical signs of TIA. Headache resolves within 24 hours. So it must be exactly at the same time as TIA, and it must disappear within 24 hours. Now, is this true or is it not true? We move on to a study done by Professor Lebedeva in Russia, and they prospectively collected 120 patients with transient ischemic attacks. Each of them had an extensive physician-conducted, validated, semi-structured interview, characterized the transient ischemic attack, the previous headache, the headache occurring at the time of the transient ischemic attack, and the duration of the headache. And that led to a proposal for better criteria, because it was, first of all, clear that headache did not always occur at exactly the same time as the TIA, and also headache did not always disappear at the time within 24 hours, and headache was not always of a new type. It was also sometimes a previous type, but with altered characteristics. So now the evidence of causation was any type of headache occurring within 1 hour of transient ischemic attack onset. Now you see it's very specific, within 1 hour. And any type of headache that occurred within 24 hours of TIA onset, if it's a new kind of headache. So in this way, it was possible to greatly improve the diagnostic criteria for headache attributed to transient ischemic attacks. This kind of field testing is something that can be done almost everywhere in centers seeing a good number of patients. It's just about getting enough patients, doing a systematic clinical study, analyzing the material in a correct way. Here's another example, a study by Professor Rigmar Jensen's group in of idiopathic intracranial hypertension. So there were 80 patients referred for suspected idiopathic intracranial hypertension, and in 36 cases we didn't find idiopathic intracranial hypertension, and in 44 cases there was. And then the headache characteristics were described in both groups of cases. We monitored the intracranial pressure, and at lumbar puncture we withdrew some spinal fluid and saw how the headache changed. And then these two groups were compared, and all this data were compared to the existing diagnostic criteria of idiopathic intracranial hypertension. And this was important for the final version of the ICHD-3 diagnostic criteria for idiopathic intracranial hypertension, which is shown here. And it says that it's a new kind of headache or exacerbation of a pre-existing headache developed in temporal relation to intracranial hypertension. Headache is relieved after withdrawal of spinal fluid to reduce the pressure. Headache is aggravated by coughing or straining. Headache has at least two of the following daily occurrence: focal localization, retrobulbar pain, and it's accompanied by at least a pulsatile tinnitus or papilledema. So again, field testing leading to a practical change in the classification of these headaches. Here we have the aeroplane headache, which we have already discussed in a previous tutorial. They got together a large number of patients, 148 males, 127 females, and they described the clinical characteristics in the next slide. And you can see that only during landing was 92% of the cases. Takeoff, 1.5% of the cases. And so it was really crucial, but the consequence has not been taken in the existing diagnostic criteria yet. I think that it should probably be restricted to headache occurring during landing, because no diagnostic criteria can be completely sensitive and specific at the same time. We have to preserve specificity, we have to accept that certain headaches cannot be included under the diagnostic umbrella of the criteria. And it's a little bit the same for field testing of trigeminal neuralgia, where the aim again was to test the clinical features and compare to the diagnostic criteria. And in doing so, we compared trigeminal neuralgia to persistent idiopathic facial pain, and then compared revised diagnostic criteria to ICHD-2 and ICHD-3 beta at that time. And you can see that ICHD-3 beta was not very sensitive, but it was very, very specific. The proposed criteria turned this around to make it very sensitive and less specific. And I think that is what we really want, because you want to diagnose the patient, you want to find all the patients, and then you can always characterize them with a number of other tests, and thereby obtain more specificity. So there's a lot to do. It's a whole field of research. Classification research is a whole field of research, and not so many people have taken it up yet, but more and more do it, and we need a lot more studies, because otherwise the next classification committee headed by Professor Peter Gutzbill will not have enough material to make the fourth edition of the International Headache Classification, which will not be forthcoming, obviously, until in 10, 15 years from now. But on the way to the fourth edition, I'm sure that Professor Gutzbill will probably publish isolated papers suggesting revision that can, at the end, be put together in the ICHD4. Thank you for your attention.